If I asked you to picture the most common eating disorder in America,
Right.
You would probably picture a teenage girl suffering from anorexia.
Yeah. Or bulimia.
Exactly. I mean, that is what the movies show us, right? It's what those old after-school specials focused on.
Yeah, totally.
And it basically just dominates the whole cultural conversation around body image. But, well, the data tells a completely different, almost invisible story.
It really does.
The actual most common eating disorder in the country affects men and women at, surprisingly similar rates. It doesn't always look the way you think it does. And for half a century, the medical establishment just completely ignored its existence.
Entirely missed it, yeah.
So welcome to this deep dive. We have an incredibly revealing stack of sources for you today.
We do.
We're looking at clinical histories, the strict diagnostic criteria straight from the DSM, and some really landmark prevalence data.
It's some heavy stuff, but so important.
Right. Our mission today is to essentially shatter the myths surrounding binge eating disorder, or BED, and we want to deeply explore the psychology of what it actually means to, lose control with food.
Because to really understand what we're dealing with today, we have to look at how modern medicine historically viewed eating.
Like how they approached it back in the day.
Exactly. For decades, it was treated purely as a math problem.
Wow, just math.
Just math. It was thermodynamics,
Yeah.
calories in, calories out.
Right.
So if a patient had an issue with their weight or their eating habits, the medical assumption was just that they were experiencing like a mechanical failure of willpower.
A lack of discipline, basically.
Right. But binge eating disorder completely upends that framework. It proves that eating is a profoundly and sometimes agonizingly psychological experience.
Okay, let's unpack this, because I think we really need to draw a hard line here on the terminology.
Definitely.
Because the word binge has been, entirely hijacked by casual culture.
Oh, absolutely.
People say, oh, I binged a true crime documentary over the weekend.
Right, or they binged on pizza at a party.
Yeah. But based on the clinical sources we were looking at, that casual use of the word does a massive disservice to the terrifying reality of the disorder.
It totally trivializes it. Binge eating disorder is not just everyday overeating.
Right.
The clinical definition of the DSM-5 requires these discrete episodes of eating objectively large amounts of food. And it has to be within a short, specific window of time.
Which is typically around 2 hours, right?
Typically 2 hours, yeah.
And the sources are very clear that this happens without those compensatory behaviors that we associate with bulimia nervosa.
Exactly. That is a crucial distinction.
So a patient with BED is not engaging in self-induced vomiting. They aren't misusing laxatives.
Right.
They aren't fasting for days afterward. And they aren't doing, punishing excessive exercise to burn off what they just ate.
That absence of compensation is basically the major clinical dividing line between bulimia and BED.
Okay, got it.
But the true defining feature, the absolute core of binge eating disorder, is what clinicians call episodic dyscontrol.
Episodic dyscontrol. Okay, wait. I struggle a bit with the objectively large amount of food part of the definition.
How so?
Because, okay, if I sit down for a massive Thanksgiving dinner, I eat an objectively large amount of food, right?
Sure, most people do.
I eat until I am physically uncomfortable.
Right.
But I am making a conscious choice to keep eating that second slice of pie. I have the wheel.
Yes, you do.
So where does, gluttony or overindulgence end and a clinical disorder actually begin?
Well, the dividing line is the wheel itself.
What do you mean?
In your Thanksgiving scenario, you have agency.
Yeah.
You are choosing to overindulge for pleasure or celebration or whatever.
Yeah, that makes sense.
Episodic dyscontrol means the agency is completely gone.
Wow.
During that 2-hour window, the person with BED experiences this profound subjective feeling that they are entirely unable to stop eating, even if they desperately want to.
So they just can't stop.
Right. The phrase that comes up constantly in the clinical literature is feeling like a passenger in your own body.
A passenger in your own body. That is terrifying.
It is. It's closely related to a compulsion or even a dissociative automatic state. The brain essentially just goes on autopilot.
So it is actually way less about the physical food on the table and entirely about the psychological terror happening in the brain.
Exactly. And that distress is mandatory for the diagnosis.
Right, the DSM criteria.
Yeah. To meet the DSM-5 criteria, these episodes have to happen at least once a week for 3 months.
Okay.
They have to cause marked distress, and they have to hit at least 3 of 5 specific behavioral markers.
And looking at those markers in our sources, they paint a very bleak picture.
They really do.
We are talking about eating much more rapidly than normal, eating until you are uncomfortably or even painfully full,
Right.
and eating large amounts of food when you aren't even physically hungry.
Which shows that the physical sensation of hunger isn't driving the behavior at all.
Wow, yeah. And then the final two markers really highlight the shame aspect of this.
The isolation, yeah.
Yeah, eating alone because of intense embarrassment about the quantity of food and feeling deeply disgusted, depressed, or guilty afterward. It sounds like a completely isolating event.
It is, which actually brings up one of the most frustrating aspects of this entire topic.
Oh.
Well, when you lay out the psychological severity of those symptoms, the obvious question is, how did the medical community manage to miss this for so long?
Honestly, yeah. How did they?
To understand how blind spots in medicine operate, we have
Yeah.
to trace the clinical history all the way back to 1959.
1959. Okay, so we are in an era where, like you mentioned earlier, obesity and weight management are viewed entirely through that crude mechanical lens.
Exactly. Thermodynamics.
Oh.
So there was a psychiatrist named Albert Stunkard working at the University of Pennsylvania,
Okay.
and he published a landmark paper called Eating Patterns and Obesity in the Psychiatric Quarterly.
And what did he find?
Well, at the time, the prevailing assumption was that if a patient carried excess weight, they must just be grazing or snacking constantly throughout the day.
Right, a constant calorie intake.
But Stunkard actually sat down and listened to a subset of his obese patients. And he noticed they were doing something entirely different.
They weren't grazing.
No, they were having these highly distinct, deeply distressing episodes of uncontrolled eating in secret.
Usually at night, right?
Mostly at night, yes. Ending in profound self-disgust. The historical accounts actually say Stunkard described patients eating until they were too tired to eat anymore.
My God.
Yeah. He realized he was looking at a specific syndrome. He called it binge eating syndrome.
Binge eating syndrome. Okay.
And he was very careful to distinguish it from night eating syndrome, which is more about circadian rhythm disruptions where people wake up and eat.
Ah, got it.
Stunkard saw the psychological distress. He saw the loss of control. He basically identified that the weight was a secondary symptom of a primary psychological mechanism.
So he planted the seed way back in 1959, and then what? The medical establishment basically just ignored him.
Completely. They just weren't ready to separate eating behavior from the simple math of weight gain.
That is wild.
So the concept essentially sat dormant in the literature until the 1980s and early 1990s.
Right, when Robert Spitzer came along.
Exactly. A psychiatrist named Robert Spitzer took up the cause.
And Spitzer is a massive figure in psychiatric history. I mean, he led the development of the DSM-3.
He did.
So if anyone knew how to get a diagnosis officially recognized, you'd think it was him.
You would think so.
Yeah.
But even Spitzer had to fight an incredible uphill battle.
Really?
Yeah. He organized these massive field trials in the early 90s. He surveyed thousands of people through weight loss programs and general population samples.
Trying to get the data.
Right, because he knew the psychiatric establishment wouldn't just accept theory. He needed cold, hard data to prove that binge eaters without compensatory behavior were a completely distinct, coherent clinical group.
Distinct from people with bulimia and from people who just generally overate.
Exactly.
But the resistance he faced is just astounding to me, because even with all of Spitzer's rigorous field data, BED only made it into the DSM-IV in 1994 as like a provisional category.
Provisional category.
They literally shoved it into the back of the book in an appendix under eating disorder not otherwise specified.
Which is such a disservice. It was flagged for further study.
Meaning clinicians couldn't even formally bill insurance for treating it as a primary condition, right?
Exactly. You couldn't bill for it.
Yeah.
And it took almost another 20 years of accumulating research, patient advocacy, and neurological imaging before the American Psychiatric Association finally granted it full diagnostic status.
Which was in the DSM-5.
Right, in 2013.
And I have to stop you here because this is just blowing my mind. Think about that timeline for a second.
I know.
From Stunkard's initial observation in 1959 to official DSM recognition in 2013, that is a 54-year gap.
54 years.
What does this all mean? How does an entire psychiatric establishment essentially ignore a severe psychological condition for half a century just because it was attached to weight?
It's because the medical community's obsession with the physical manifestation of weight entirely eclipsed the psychological suffering of the patients.
They couldn't look past the scale.
They really couldn't.
Yeah.
And the consequence of that 54-year delay is that it allowed the disorder to spread entirely under the radar. Because medicine ignored it, culture ignored it.
It became a hidden epidemic.
Exactly.
And the numbers on this epidemic are what completely blindsided the medical community once they finally started looking. Here's where it gets really interesting for you listening.
Oh yeah, the Hudson data.
Right. In 2007, a researcher named James Hudson analyzed data from the National Comorbidity Survey replication. And this wasn't some small clinical sample.
No, it was massive.
It was a massive, nationally representative U.S. mental health survey.
And Hudson's 2007 data changed the entire landscape of how we view eating disorders.
Because it revealed that BED had a lifetime prevalence of 3.5% in women and 2% in men.
Right.
To put that into perspective for you, that means binge eating disorder is more common than anorexia and bulimia combined.
It's staggering.
But because of the cultural coding we talked about earlier, it gets almost zero visibility in pop culture. And that lack of visibility breeds incredibly dangerous misconceptions.
Starting with who actually suffers from this.
Yes, the gender misconception. Let's unpack that.
So with anorexia and bulimia, the female-to-male ratio is really stark. It's roughly 9-to-1, sometimes even 10-to-1.
Right.
So those disorders are heavily culturally coded as women's issues. But BD has a 3.5% to 2% ratio.
So it has a much, much narrower gender gap.
It is surprisingly gender balanced.
Meaning men are suffering from this at incredibly high rates, but because the cultural narrative says eating disorders only affect teenage girls, these men might not even possess the vocabulary to realize they have a treatable clinical condition.
Exactly. They probably just think they lack discipline.
That's heartbreaking.
It is. And the lack of vocabulary prevents people from seeking help. But the second major misconception is perhaps even more dangerous on the clinical side.
Which is the assumption about weight.
Right. Because BED was studied for so long exclusively in obesity clinics, going all the way back to Stunkard, people assume BED and obesity are synonymous.
Which they're absolutely not.
No, they're not.
The sources emphasize that while BED is frequently comorbid with higher body weight, a substantial number of people with BED are of average or even low body weight.
Which means if a clinician is diagnosing based purely on physical appearance, waiting for a patient in a larger body to walk through the door, they are dangerously missing normal weight individuals.
People who are experiencing profound psychological distress and loss of control in total secret.
Exactly. And this historical misunderstanding, treating BED as just an obesity issue, lead to a really dark chapter in the treatment of the disorder.
Yeah, the sources get into this. For decades, the standard treatments doctors recommended were not just ineffective, they were like actively harmful.
We referred to this in the field as the dieting trap.
The dieting trap.
Yeah. For years, because BED wasn't an official diagnosis, patients went to their doctors or weight loss clinics seeking help for their binging behavior.
Because they knew something was wrong.
Right. And the only metric for success in those clinics was pounds lost. So doctors put these patients on rigid, calorie-restrictive diets. They impose strict food rules.
Okay, wait, but if dietary restriction triggers a binge, that puts a doctor in an incredibly difficult position, right?
So?
Like, if a patient comes in with BED and severe weight-related joint pain, a doctor's instinct is going to be to prescribe weight loss.
Naturally, yeah.
But you're saying doing that is effectively clinical malpractice.
In the context of active binge eating disorder, yes. The tragic irony is that rigid dietary restraint is a known, documented psychological trigger for loss of control eating.
Wow.
You are putting immense psychological pressure on a neurological system that already struggles with episodic discontrol.
So prescribing a strict diet to someone with BED is essentially like throwing gasoline on a fire.
That's exactly what it is. The restriction itself is the very thing that triggers the disorder you are trying to treat. When the restriction inevitably breaks, the rebound is a severe binge.
So what does effective evidence-based treatment actually look like then, if you have to take diets completely off the table?
You treat the mind, not the plate. The most successful approaches center on cognitive behavioral therapy, or CBT.
Okay, CBT.
And interpersonal psychotherapy. Instead of handing a patient a meal plan, a CBT therapist helps them identify the micro moments before a binge occurs.
Right, so like if the trigger is the feeling of intense loneliness at 9 Mindia.
Yes.
Exactly.
Right.
CBT gives the patient a specific cognitive tool to deploy at, say, 8:55 p.m. to prevent the brain from slipping into that automatic dissociative state.
It interrupts the behavioral chain. It builds distress tolerance so the patient can sit with negative emotions without using food as a dissociative coping mechanism.
That makes so much sense. Our sources also point to a massive milestone on the pharmacological side, which I found totally fascinating.
Oh, the Vyvanse approval.
Yes. In 2015, the FDA approved a medication called Vyvanse. The generic name is lisdexamfetamine dimesylate, as the very first medication specifically approved for BED in adults.
Right.
And what's wild is that Vyvanse is an ADHD stimulant.
Which was a watershed moment for the legitimacy of BED.
Oh, so?
It wasn't just an off-label use, The FDA gave it a primary indication. It signaled to the medical world that BED was its own neurobiological reality worthy of its own clinical trials.
Not just a byproduct of depression or a symptom of obesity.
Exactly.
And the crossover with ADHD makes a lot of sense when you understand the mechanics of it, because ADHD is fundamentally an issue with executive function and impulse control, right?
Right.
So if a stimulant helps regulate the braking system in the brain for someone with ADHD, it stands to reason it could help regulate that terrifying feeling of episodic dyscontrol in a Beyblade patient.
That's exactly the mechanism. Vyvanse speaks directly to the dopamine and reward circuitry in the brain. It helps stabilize the neurotransmitters that manage impulse control.
Fascinating.
But, and this is a big but, that exact dopamine connection leads us right into one of the most intense ongoing debates in the psychiatric field today.
Okay, which is?
Is binge eating disorder best understood as an eating disorder or as a food addiction?
Oh, wow, that distinction carries a lot of weight. Calling it an addiction fundamentally changes how we view the patient's relationship with food.
It really does. The food addiction model is championed heavily by neuroscientists looking at brain imaging.
And what do they see?
When they scan the brain of a BED patient, they see that the reward anticipation and the impaired inhibitory control look remarkably similar to the brain scans of someone with a substance use disorder.
So the neural pathways lighting up in anticipation of a binge mimic the pathways lighting up for drugs or alcohol. But the critics of the addiction model push back hard on that, right? The counter-argument in our notes is that no single food, even highly palatable things like sugar or fat, has been proven to be chemically addictive in the same isolated physiological way that nicotine or opioids are.
Yes. And the critics raise a really vital philosophical and clinical point there.
What's that?
They argue that labeling food as addictive moralizes eating. We have to eat to survive.
Right. You can't just quit food.
Exactly.
Huh.
If you tell someone they're addicted to food, you risk increasing their shame around the very act of nourishing themselves. And as we know, increased shame is a primary trigger for more binging.
It highlights just how complex navigating recovery must be. You can't simply abstain from food the way someone in recovery might abstain from alcohol.
You can't.
You have to learn to interact safely 3 times a day with the very thing that triggers your episodic dyscontrol.
It is an incredibly difficult tightrope to walk, which is why specialized compassionate care is so critical.
Definitely. So as we synthesize everything we've covered today, I really want to clarify exactly why understanding this history and psychology matters so much for you, the listener.
This is vital.
If you take away nothing else from this deep dive, remember this. Binge eating disorder is not a lack of willpower.
No.
It is not a moral failing. It is not synonymous with obesity. It is a severe, intensely psychological disorder that requires clinical compassion and targeted therapy, not a restrictive diet plan.
The tragic reality of BED's low visibility is that right now there are people, maybe people you know, who are suffering in complete silence because they don't look dangerously thin, or because they're men who believe eating disorders only affect women. They go years believing their secret, distressed eating, is just a personal defect.
When in reality, they simply don't know they have the most common, highly treatable clinical eating disorder in the country.
Exactly.
Which brings us to one final, really provocative thought from the researchers that I want you to cue on today.
Yeah, the subjective binges.
Right. In the ongoing debates over the DSM criteria, some researchers have been heavily focused on a phenomenon they call subjective binges.
And a subjective binge is a fascinating challenge to the current diagnostic rules.
Because it removes the objective quantity part.
Exactly. It is an episode where the actual caloric size of the meal is totally normal.
Yeah.
Like maybe it's just a regular size sandwich and a small bag of chips.
So it is explicitly not an objectively large amount of food.
Right.
But the person eating that normal-sized sandwich experiences the exact same intense, terrifying feeling of lost control. They enter that same dissociative state.
And evidence is growing that this internal subjective experience of terror predicts a person's psychological impairment far better than the physical portion size sitting on their plate.
Wow, so the physical amount of food almost doesn't matter.
The psychological distress is exactly the same, whether it's a feast or just a sandwich.
So, think about what that implies. If the true severity of binge eating disorder might eventually be measured purely by the internal feeling of losing control, rather than the physical, measurable amount of food on the table.
What does that mean for how we define other mental health struggles?
Exactly. Are we as a society too obsessed with measuring the physical output of pain?
We always want to see the physical proof before we offer the compassion.
Right. We want the neat categorizations. We want the math.
But maybe it's time we accept that when it comes to the human mind, the math just doesn't work.
The visible metrics fail us. And the sooner we get comfortable navigating the invisible, subjective experiences of psychological pain, the sooner people can actually get the help they need.
Well said.
Thanks for joining us on this deep dive. We'll catch you next time.